Thank you, everyone, for taking time to join us this evening. Today, we have an excellent presentation on the global pregnancy guidelines. My name is Marie-Louise Martin. I'll be your moderator, and our speaker tonight is the Honorable Dr. Cynthia Seow. Switch slides. So I'd like to take a minute to do our land acknowledgement. On behalf of the CanIBD Nursing Board, we would like to take a moment to acknowledge the Indigenous people of all the lands that we are joining from today. While we meet today on a virtual platform, we recognize the importance of lands which we each call home. From coast to coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nation people that call this land home. Today's webinar is hosted by CanIBD, which is a consortium of nurses living across Canada working in the field of inflammatory bowel disease and is supported by CCC. Our vision is to ensure people of all ages living with inflammatory bowel disease in Canada receive high quality clinical nursing care within a multidisciplinary team. We are committed to improving the quality of care for people living with IBD by providing mentorship and learning opportunities, creating opportunities for networking and sharing of best practices, as well as developing and adopting nursing guidelines and evaluating the profile of IBD nursing in Canada. Next slide, please. So it's my honor to introduce Dr. Seow, who's a professor and clinical researcher in gastroenterology. She has an interest in special pediatric to adult transition, preconception and pregnancy in IBD, and pharmacology, and she's one of the world leading experts. Thank you, Dr. Seow, for your time. Please save any questions towards the end, or you can put them in the chat box and we'll answer them as we go.
Thank you, ML, and thank you to CanIBD and CCC for the opportunity to present today. I wanted to present on the global update on the management of pregnancy and IBD. To let you know, some of these slides may be familiar to you if you have referred your patients to the gut talks that Vivian Huang and myself presented for the CCC patient education series, because I have purposely used the same slides, but we'll be giving more in-depth information today than we gave for the patient portal. But I thought it might be useful for you guys that if you do refer patients to the webinar subsequently and they have more in-depth questions, then hopefully you'll be equipped to answer them after having this presentation. And as ML said, I'll be more than happy to answer any questions at the end, or if there's anything burning in the middle, ML will certainly interrupt and I'll be happy to answer those. So I wanted to first introduce the Global Consensus on the Management of Pregnancy and IBD, which was an initiative that we convened over actually 2 years, and it was published in the latter half of 2025. There were actually almost 50 of us involved, obviously globally, and I was fortunate to lead the North American section as well as the medications in pregnancy section. And I think what was unique about these consensus guidelines was that not only did we have IBD physicians, we had nurses, pharmacologists, placentologists, neonatologists, obstetricians, surgeons, as well as teratologists. So it was a really multidisciplinary effort. And why it was important to make it global is we know that there are different access to resources around the world. So sometimes people misconstrue information if they think that it's not relevant to them, if they don't have those drugs in their territory, or they don't learn about what is available in other regions. So we are very fortunate in Canada because we have very easy access to medications, but I think we still have to be familiar with a lot of the other non-advanced therapies, because some of our patients who aren't so sick or are traveling or are visiting from elsewhere may be exposed to these other medications. So there were 10 main sections in the global consensus, and I will be going through them, but really want to make this a little bit case-based and practical. So the learning objectives were to describe the impact of IBD on pregnancy outcomes and the impact of the pregnancy on IBD, to assess IBD activity and provide optimal management preconception and during pregnancy, and to evaluate safety of medications during pregnancy and breastfeeding. And I forgot to mention that these guidelines are actually published across 6 major gastroenterology journals. So if you want to look at those, you can simply go to the website Piano IBD. So just like playing the piano IBD, you will see that there is a short 2-minute video for patients. There's also a link to the consensus guidelines, and then there's also links to multiple in-depth videos that healthcare practitioners can use. So I encourage you to go to the Piano IBD website. So I wanted to start off by just orientating you with a case. So this is a 24-year-old with Crohn's disease affecting her colon and ileum. She also has perianal disease, and for that reason, she had been historically treated with infliximab as well as methotrexate. And she's getting married in a few months, and she asked a gastroenterologist several questions. The first being, will my child have IBD? What factors will influence my ability to get pregnant? And who and why should I see you before a pregnancy? So if you look at this, this is a fairly common case scenario, perhaps the methotrexate not as common as the infliximab, but we always have to be aware, and part of the reason we made this representative case was that we don't make assumptions about patients' preferences for life. You might think, oh, she's 24 years old, but had she been 18 years old, is she too young? Do we have to worry about her being on methotrexate? Is she even considering a family? So, as Marie-Louise well knows, when we do our pediatric adult transition clinic, we start off the discussion about family planning, or at least a life journey, very, very early. And you've heard many of us discuss, sex, drugs, rock and roll, where we say that the drugs are the patty in your hamburger, and to make a good hamburger, you need to have a good patty. But you also have to make sure that the top bun is, the discussion about sex, which is really more about relationships. What are they planning in terms of a family? When would they like to get pregnant, if they even want to get pregnant? And then other discussions regarding things like sexual dysfunction, body image, and all of that are important. So that's the sex part of it. Drugs are the middle of it, because if you are on the correct drugs, it allows for the sex and the rock and roll. And the rock and roll is obviously what they want vocationally, or for vacation, or for education. So it's never too late to start this discussion. So particularly when you have a patient on methotrexate, you're going to have this discussion early. So a common question is, what are the factors that affect the impact the pregnancy? And these are the 10 core attributes in the global consensus, but you will see that we'll cover them through these case histories. So maternal factors affecting pregnancy. Will my child have IBD? Every mum worries about this. Nobody wants to feel that they're at blame for a bad outcome. And I always try and reassure my patients that, IBD is multifactorial. You're all very familiar with the GEM study, so it's genetics, environment, and microbiome. But even though the G stands for genetics, that only plays a small part really in the idiopathogenesis of IBD. And in fact, that there are 200, 300 type mutations in IBD. So it's not one of those diseases where there is really strong penetrance that you would see in other sort of genetic disorders. So I always tell patients, you can't change your genes, but let's focus on modifiable factors. And that includes starting them on a prenatal vitamin that includes folic acid, as well as iron and other micronutrients early on in the game. Concentrate on healthy weight gain. And of course, patients only have an appetite if they're feeling well. So sometimes that goes hand in hand. And then, of course, all the general advice that you would give to any pregnant patient to avoid alcohol and smoking. So that is an important, discussion point with patients because they all are worried, and we know that there is a slight increased risk of IBD if both parents have IBD. But to be honest, I don't tend to put a number on it because I just think that it makes people more worried than anything else. So focus on the modifiable factors. So, what is the true role of genetic smoking, diet, infections, antibiotics on the future risk of IBD? And you can see from this nice paper here that, as we said, smoking plays a role, whether it's active smoking or passive smoking. Antibiotics, changing the microbiome matters. And so, if the mom is on antibiotics or the babe later is on antibiotics, that can change the microbiome. So, again, of course, if you have active infection in pregnancy, it should be treated. But judicious use of antibiotics is important because, as we well know, most of the infections that women with IBD are predisposed to are often viral and do not require antibiotics. So this takes you through, the risk between perinatal all the way to childhood. And as we said here, just be more concerned about modifiable factors of diet, smoking, and antibiotic use. A shout out, as I already mentioned, to the GEM project. And, in the future, particularly for Crohn's more so than UC, there's a lot of research into how can we combine all these risk factors to predict risk. And if you look at the GEM project, I think it's a super exciting project looking at that Ken Croitoru, Sunho Lee, and all of that are involved in to see whether they can come up with a risk model in the future. So if you have questions about maternal factors, please feel free to pipe up and ask. Otherwise, again, we will answer the questions at the end. So fertility, what factors influence the ability to get pregnant? So Layla wonders about this. She's 24. We know that as people get older, that risk increases. That's the same as the general population. But clearly, any medical condition can impact on the ability to get pregnant. And when we talked before about sex, drugs, rock and roll, we also know that if a patient is feeling unwell, there are risks before they even consider pregnancy. They may not have libido. They may not have that urge to want to be active or intimate if they have got active disease. Not just because they have active perianal disease, not just because they have a stoma, but if they're worried that they're going to leak, for example, that really doesn't help at all. And the same goes for any of the other immune-mediated disorders, such as if they have bad skin, they might be worried about their body image. If they have sore joints, they might not just really feel in the mood either. So controlling IBD activity, as you can see in green, but also controlling activity of any other chronic immune disorder or any other disorder is important. And then when we look around at this, of course, they're gynecological factors. And it's interesting because everybody says, well, we're just focusing on the female here, which is true for this presentation. But always remember, it's not always the female. And it is important if they're doing a fertility assessment for both male as well as females to be assessed, because clearly there can be other factors such as sperm health and other things that can impact a lady's ability to get pregnant. Pelvic surgery does impact to some extent. As you well know, patients who have undergone a total proctocolectomy, if there's been a lot of pelvic involvement, then you develop adhesions. And as you know, when you have adhesions, then the fimbriae will not be so motile and not move so well, and therefore you might not be able to get the egg across. So that adhesions in itself can be a mechanical barrier to getting pregnant. That is why when you see some of the younger women who have had a colectomy, that they do a colectomy first, but they do not remove the rectum until after childbearing because of that potential risk for reducing fertility. There have been improvements, though, over the years, and you will hear that many of these colectomies are now actually done laparoscopically, and this may reduce the risk. The data for that is not very clear at the moment. It's low-level data, but it'll be interesting over time whether there are improvements in fertility with using specialized surgical techniques. Substance abuse goes without saying, whether it is cigarette smoking, whether it is cannabis, anything else, all these things can impact a woman's ability to get pregnant, as well as of course, the maternal as well as the fetal health subsequently. And the same with nutrition. And really, I will always mention this. Please ensure that your women are iron replete prior to the pregnancy. We know that oral iron is not always all that well absorbed. When women in their first trimester get hyperemesis or are feeling nauseated, they will not want to take your iron pills. And then in addition to that, then their bowels changed in the pregnancy. Then they don't want to take the iron pills yet again. And you cannot really give IV iron in the first trimester. It's not advised to. You would have to leave it for the second trimester. Let your women enjoy their pregnancies. So correct as many of these things as you can before they embark on a pregnancy. And so, in general terms, we always say that if a woman is trying actively for 6 to 12 months and has not got pregnant, of course, they should be mentioning it to you, making sure that the disease is under control. That's the part that you can help them modify. And if their disease is well under control, then you need to be looking at the other factors and have a low threshold to refer them for fertility assessment. And remember that fertility assessments are covered by most, if not all, the provincial health plans. Of course, the assisted reproductive therapies such as IUI, ICSI, IVF are not covered, but the assessment, doing an HSG, the hysterosalpingogram, doing all those other assessments, sperm motility and all that are usually covered. Okay, and Marie-Louise, just please feel free to interrupt if there are any questions in the chat because I can't quite monitor it while speaking.
No questions right now.
Okay, thanks. So preconception counseling and optimization is important, and we really actually touched on a lot of this already because I always think it always gets away from me because I just think it's such an important topic. And as Layla says here, and sorry for the typo at bottom, formatting issue, I may not be considering pregnancy right away. So why should I see my IBD doctor or healthcare team I should put before pregnancy? And these are the basic tenets. And I think you are all so very familiar with this. Best for IBD to be in remission for at least 3 months before conception because it gives you time. That's what you want. You want time to optimize the medical therapy. You don't want to be waiting and then going into salvage mode. We know that preconception counseling will improve medication adherence, and we'll talk more about the specific medications soon. But again, that 3 months lets you optimize, but it also, when we talk about optimizing, it's not just what the current drug is, but should they be changing to another therapy? In the case of Layla, should she be on the methotrexate or not? And clearly, we wouldn't want a female to be on methotrexate whilst pregnant electively. And ultimately, we want to reduce the risk of disease relapse during pregnancy because the biggest goal for any pregnancy is getting that pregnancy to term, which is defined by a pregnancy of 37 weeks and more. And I always tell my patients, before 37 weeks, yes, the babies are small, they are cute still, but the biggest concern is that they do have a immature immune system and an immature neurological system. And even with the moment you present that to patients, they understand if they're immature, if there's an immature immune system, the babies are not able to fight infection. It's as simple as that. So I really, really hone in on that because their next question will naturally be, what about the medications? Isn't that what predisposes to infection? And I keep reiterating to them, the medications keep your disease under control. They allow you to get to term. By getting to term, the baby has a really strong immune system and is able to withstand any or most of the threats. And we'll go again into medications soon. But really reiterate that they need to have a strong immune system. And neurologically, no mum or dad wants their kids to be, at risk of not being able to learn or, being the best person they can be. So when you put that into context of management of disease activity during pregnancy, I'll just switch gears a bit and give you another case because we talked a little bit about Crohn's disease and we can come back to this in Q&A. But I really want to present to you a woman who has ulcerative colitis on mesalamine prior to and during her pregnancy. And I'll give you the spoiler alert now. It is the UC patients that cause the most heck during pregnancy. Absolutely, they do. They are far more at risk of having a flare during pregnancy, 2 to 3 times more likely than patients with Crohn's disease to flare, even if their disease is well controlled prior to the pregnancy. And this is a really common scenario. Patient is now 18 weeks pregnant, has noticed an increase in bowel movements up to from 1 to 4 to 5 a day, loose stool, and is now starting to notice blood. So when you talk about treating to target, you really need to treat to target, especially in these UC patients. And we've already discussed most of this, but I just wanted to keep the flow for all the points that disease activity increases the risk of adverse maternal and fetal outcomes, as well as things like spontaneous abortion, stillbirth, lower gestational age. We really have to be careful. So, what can we do in these IBD patients, and specifically the patients with UC? How do they know if they are having a flare or if the symptoms are pregnancy related? And can you do the same testing? And again, spoiler alert number two, exactly the same testing, almost exactly the same treat to target that you would do for a pregnant versus a non-pregnant woman. You need to actually even monitor even more carefully during pregnancy. And as we said here, women with UC, different studies, 2 to 3 or 3 to 4 times more likely to flare than those with Crohn's disease. But the good news is that the fecal calprotectin is a reliable marker of inflammation in pregnancy. So I always take a step back. I ask the patients, especially with your UC patients, what is the first symptom that they're going to get? They get the tenesmus, the sensation of incomplete emptying first. Then they get the urgency. Then they get the frequency. Then they get the bleeding. By the time they've already got the bleeding, I always say to them, you should have come and told us about this earlier. Because remember that irrespective of what therapies they're on already, UC always starts in the rectum and works proximally. So you can add topical therapies such as a suppository to any regime, whether that woman is on risankizumab, whether that patient is on infliximab, whether that patient is just on oral 5-ASA or azathioprine. You can always use 5-ASA rectal therapy as an adjunct. And as you'll hear in the medication section, it is very safe. It's actually well tolerated. And yes, we are all aware that the uterus is near the rectum. And patients, I don't know, I always ask that. It does not increase the risk of preterm birth by putting in a suppository. Just remember that you're calming down that disease, and it is important. So again, ask about symptoms, but make sure that they're reporting early about tenesmus and urgency before they even get to the bleeding stage. Blood work is not super helpful because the CRP bumps around all the way in pregnancy, as does ESR, which we generally do not use. Fecal calprotectin is a reliable marker. And then we will sometimes scope patients only if it changes immediate management. And that is in patients with UC, where you can do a sigmoidoscopy during that pregnancy because you'll get your answer within 10 centimeters as whether they're flaring. But we are so fortunate in Calgary, and it's expanding all around Canada, to be able to use bowel ultrasound to assess bowel wall thickness as a non-invasive way to assess disease activity. And you can do a bowel ultrasound up to about 26 weeks gestation. Beyond that, baby steals the show and it's hard to see. But just remember, you can do all of these things, and best to do them all before the pregnancy. But then when they are pregnant, my standard regime is everything beforehand. First trimester, fecal calprotectin. Second trimester, if they have Crohn's disease, you can do the bowel ultrasound if you're looking specifically for ileal disease. I don't tend to do bowel ultrasounds in the pregnant UC patients. I don't find it quite as helpful. And then you repeat the fecal calprotectin in the third trimester, knowing that the fecal calprotectin doesn't tell you just how you are now, but it can predict a flare 3 months in advance, which conveniently is 1 trimester. And only do endoscopic evaluation if it's going to change your management. But if a patient appears to be flaring and has UC, in pregnancy and you've excluded infection, which you would always do anyway, and they've still got ongoing disease despite using suppositories, which you can just start empirically, I wouldn't reach out and ask for a rectal or deep pelvic ultrasound. Do the sigmoidoscopy, can be done safely in pregnancy. We do recommend fetal heart rate monitoring for your practitioners before and after the sigmoidoscopy, not because the sigmoidoscopy will risk losing the pregnancy. It's because the active disease in itself may have already had an impact on that pregnancy. And if you already have, the woman is not aware, but is already experiencing a fetal loss, and you do the sigmoidoscopy, they will blame it on the procedure, not on the active disease. So that's just a pointer. All of your hospitals will have labor and delivery and triage nurses who will be happy to come down with a handheld to check the fetal heart rate monitoring before and after the sigmoidoscopy. And remember, the active disease can occur in the absence of symptoms too. So moving on to the management during pregnancy, if your woman is already pregnant, one of the things I really didn't want to forget to mention was the use of aspirin, because that has been kind of a funky topic since the consensus was published, and then we'll get onto all the medications later. I always leave that for last because that will stick in your brain and then people always have questions about it. But aspirin is used to try and reduce the risk of preterm preeclampsia and is used in any high risk pregnancy. We don't in Canada or in Calgary specifically empirically put every woman on aspirin prior to 16 weeks of pregnancy because IBD is only one risk factor for preterm preeclampsia. Other people would argue that it's really low risk and the risk of subchorionic hemorrhage and things are relatively low, but I don't know. My counseling is I say, well, not everybody is on Tylenol every day just to prevent, you getting a knee ache walking to work. I don't empirically give medications if they're not necessary. I work with the family doctor and the obstetrician to say, are there other risk factors? Nulliparity, family history, previous preterm preeclampsia, other diseases such as SLE, so lupus, and others that affect the vascular supply. But it is important to know that if the woman is advised to go on 2 baby aspirin a day for the prevention of preterm preeclampsia, that this does not increase the risk of a disease flare. And the rationale for using the aspirin is that it was based on this New England study and it affects and impacts on the placental microvasculature. So again, you can consider aspirin. Our labs provide, our sonographers actually provide an assessment at 12 weeks for all of our pregnant women. We're really fortunate in Alberta, and I'm not sure how widespread it is, that at the time where they do the fetal ultrasound, they actually also give an estimate of the risk for preterm preeclampsia. So if I see on that assessment high risk, I put them on the aspirin at that 12-week ultrasound and continue. If it says low risk, I don't introduce it. But I think that is a more is potentially a more accurate way of risk stratifying a patient rather than just going by the other risk factors. So again, make sure that the patient has spoken to their family doctor about it. Make sure that they know the general risk factors for preeclampsia. Look at that 12-week ultrasound and then make a decision about aspirin. If they go on aspirin, they start it between 12 and 16 weeks of gestation and continue it out to week 36. Other questions for obstetricians are, does the patient need a cesarean delivery? We would consider gastroenterology reasons. That includes active perianal disease, ileoanal pouch surgery because you don't want to tear into that pouch. But all the rest are actually obstetric indications, meaning that, baby's head might be too big, baby's feet first, baby's sunny side up. Those are obstetric reasons. They're not GI reasons for preferring a cesarean section. And of course, there is personal preference. But again, we had seen probably several decades ago that there was a very significantly higher rate of cesarean sections in IBD patients, but that practice has changed over the years and benefits the women to have a vaginal delivery if they can. So there you go again, active perianal disease, ileoanal pouch, rectovaginal fistula, and obstetric indications. So moving on to the big section, IBD medications during pregnancy. Sabine asks you, can I continue using my IBD medications through pregnancy? General advice, very simply, be more concerned about active disease than active medications because the majority of IBD medications can and should be continued. And hopefully, I've set the background that it is active disease that leads to the adverse outcomes, not the active medications. And again and again and again, when you're looking at infectious risk, that is mostly related to a preterm birth rather than the effect of medications. There are lots of medications that that are used in IBD, and this is a huge section. And this is a section, of course, I have a vested interest in because I led the medications and pregnancy section. But it took up almost a third of all the grade statements and almost a quarter of the consensus statements because really these are the things that you can potentially modify for a better outcome because you need these in order to optimize disease control, and you need to get your patients on board with understanding why they need these medications. So we were, at the launch of the IBD consensus guidelines, just the week before, Trump had put out this headline, which I'm so sure you all saw, that he was linking autism and Tylenol during pregnancy without conclusive evidence, which really does harm our patients because they see all this on the media. And if they think they can't take Tylenol, they're not really that keen to take our medications. So we're going to go through these medication classes, but don't worry, I'm going to simplify this. But in essence, these are the classes of medications, and you can see that there are only a few obvious X's. And guess what? They all end up on methotrexate. Methotrexate is clearly a teratogen. We talked about optimization prior to pregnancy, and women should stop methotrexate preferably 3 months prior to conception. But when we say stop it, they need to have a contingency plan. They need to be on appropriate other therapy. You don't just stop it and see how it goes because we know how it will go. And very importantly, if a woman is on methotrexate, and you'll see this again on another slide, but I want to say it more than once, if a woman inadvertently, in inverted commas, gets pregnant, because we know a lot of pregnancies are not planned whilst they're on the methotrexate, that does not necessitate immediate termination of the pregnancy. Please ask the patient to tell you, get obstetrics involved. They will do the counseling. They can do the scans because not every exposure to methotrexate will lead to methotrexate embryopathy and the whole range of congenital malformations. They need to be counseled appropriately. And very importantly, they should be exposed to high dose folic acid straight away. We're looking at 2 to 5 milligrams of folic acid because that has been shown to reduce the risk of methotrexate related embryopathy and malformations. We'll talk a bit further on the next slide about JAK inhibitors and S1P modulators, but in essence, you're not going S1P modulators. There are more effective and safer therapies. I do like them as a class of drugs, but it's not in the same sort of class as JAK inhibitors, where often you are putting a patient on a JAK inhibitor because you've already tried other therapies to minimal effect. So this is what I had already said about methotrexate, but again and again and again, because everybody sees all those X's, they think about termination straight away. I would say practical considerations, time to transition, stabilize on other therapies, consider folic acid supplementation, as we know from this old study from 2000 New England Journal, that if you give high dose folic acid, you can potentially reduce that risk of congenital malformations. Corticosteroids, so important. This message is that if your patient is actively flaring, don't withhold steroids. And I'll repeat that because people will say, what? We would say if it is clinically and necessary, you should start steroids with appropriate monitoring if you need to get that disease under control quickly, because we know that steroids are an effective induction agent. You need to get that disease under control quickly. We know based on systematic reviews and meta-analyses that it doesn't increase the risk of congenital malformations. Yes, everyone talked about cleft lip and palate, but that was at a time when it was used for a number of diseases. The active disease in itself can be a teratogen. If your woman is sick, I don't faff around with budesonide. I don't do a half-hearted approach. If they're sick enough to require steroids, give them prednisone. Because what will happen is if you put them on budesonide, whether it's Entocort or Codiment, then what? They kind of respond after 4 weeks. You're not really sure. Do you up it now? Do you change to prednisone? 4 weeks and then a full 8-week course of budesonide is a long time in the context of a pregnancy. If you need to treat, make sure you're monitoring for blood pressure and monitoring for diabetes. 5-ASA, we've said multiple times before that if you are going to use it, use rectal therapy as a rescue therapy for your patients, and it is very well tolerated. But we also know that 5-ASA is often stopped in our patients because they think it's a lesser drug. It isn't. And make sure that you counsel them about rectal therapy. Thiopurines, there is no increased risk of congenital malformations or serious infections. We know that there is shunting during pregnancy, so there's an increased risk of intrahepatic cholestasis, but that already occurs in 1.1% of the general population. So, when the FDA put out that announcement, you will see some abnormalities in liver biochemistry, but it doesn't mean that you need to stop the azathioprine. If you see that abnormal biochemistry, you will consider splitting the dose. And I'm seeing some questions, and I will answer those in between or after. Anti-TNF therapy, along with all biologic therapies, these are huge molecules. They do not cross the placenta in the first trimester. There is steady transfer in the second and third trimester. But the good news is we have not seen any risk of congenital anomalies because of the biological plausibility. It doesn't cross the placenta, baby doesn't see, smell, or hear it. And when you continue it, even in the second and third trimester, and even if there are detectable levels in the babies, we have done studies doing the immunophenotyping of these babies and shown that they have normal immune function despite exposure to the anti-TNFs or other biologic therapies. So in the old days, they used to talk about stopping it, changing the doses, spacing out the doses. We no longer do that. Continue with no change in dose, no change in dosing schedule throughout the pregnancy. Normalize it for the woman. The more things that you say, oh, you should stop this, start this, hold this, they will just get freaked out and they won't do it. You continue it all the way through the pregnancy. We know that when we used to recommend stopping it earlier in the pregnancy, we would find that there was, in fact, actually an increased risk of disease flare that required more rescue therapies such as steroids, and that in itself, as we said, preterm birth increases the risk of infection. So again, no changes to dose or dosing schedule. All biologics continue all the way through pregnancy. And even with that, and us using higher doses than rheumatologists and dermatologists, even rechecking the drug levels in the baby, when we immunophenotype them, they had normal immune function to the point, as you'll hear soon, that you can give these babies all the standard vaccines, including the live oral rotavirus vaccine for anti-TNF exposed babies. We are still trying to publish the data on the safety of giving the live rotavirus vaccine for other monoclonal antibodies, but now public health will just automatically give these anti-TNF exposed babies the live rotavirus vaccine in addition to all the other vaccines. That's how safe it is. And as we said here, it reduces the risk of preterm birth with no increased risk of serious infections. And there are multiple studies on this. Oral small molecules, everybody is asking, what do you do about them? So you wouldn't preferentially put a woman who is considering pregnancy on an oral small molecule, whether that is an S1P modulator or a JAK inhibitor, if you have other options. But we know for the JAK inhibitors that shared decision making is imperative. We're part of a global registry for JAK inhibition and exposure in pregnancy. In fact, actually, Calgary's got the largest number from a single site in the world because we have seen very refractory patients. Again, you have to discuss with them that if you were to switch therapies, you need to incorporate time to transition. You don't just say, oh, you're going to get pregnant. Okay, let's stop it today and start something tomorrow because you don't know if the other therapy will work. And the majority of the people who are on a JAK inhibitor have failed multiple other therapies. That is why we made the statement, if there are no other effective alternate therapies to maintain maternal health, continue it, given the totality of data supports stringent disease control. We take a lot of calls about this, and we would really recommend that patients, if you're uncertain or your physicians that you work with are uncertain about it, please refer. We're happy to do phone calls. We're happy to talk about other strategies for these patients, but sometimes it just requires careful monitoring because if you stop the drug, the patient will flare. Remember, again, you don't need to actually be reminded that IBD is a chronic illness. We don't just stop the drug, hope that they'll get pregnant, don't use it in the first trimester because we're worried about teratogenicity. Restart it in the second, third trimester, and then stop it again for breastfeeding. That's not how it works in real life. We can't predict when a woman will become pregnant, and the half-life is so short. You stop it, the person will flare. So if you say, "Well, I think she's going to conceive in like 4 weeks' time. I'll stop it now," what do you think will happen? Yeah, that might match with the half-life, but that woman will be very likely to flare at the 4-week mark at the time of conception. And then that puts the rest of the pregnancy at risk. Similarly, can you continue using IBD medications while breastfeeding? Generally, breastfeeding does not increase the risk of disease flare, obviously good for bonding, no increased risk of infection in babies who are breastfed while mums are on biologics for IBD. So no increased risk for 5-ASAs, no increased risk for Imuran. All of these drugs, just continue them through breastfeeding. The only exceptions are methotrexate, and we again have that very detailed discussion about women who are on JAK inhibitors. Don't use it electively, but sometimes you don't have a choice. And when you look at the transfer of monoclonal antibodies in breastfeeding, less than 10% is considered safe. It's less than 0.005% for the biologics. Okay, and LactRx is a good resource if you need to use it. And always respect maternal choice regarding breastfeeding. Last little bit, women with IBD at increased risk of pregnancy outcomes, and what do you do to avoid the situation? We've already covered this. I tell every patient the same things. Be more concerned about active disease and active medications. And very simply, I tell them, your body needs to focus on baby, not on your bowels. And that usually resonates. And so that has an impact on birth weight, timing of delivery. And remember that active disease also increases DVT risk. So if they have active disease, you might end up having to put them onto blood thinners as well, which is a big thing. So in summary, when you look at the global consensus, these were the summary statements. I will refer you back to the website to look at it, but hopefully we've covered most of this now. And I know we're going to open up to question and answer, but just wanted to familiarize you with this, that the clinical guidance here is that you continue all biologics and thiopurines during pregnancy and lactation. Avoid small molecules where possible during pregnancy and lactation. Provide preconception counseling. Provide low-dose aspirin. That was really a suggestion. It was not a consensus recommendation for the caveats I've provided. I think in third world countries, they don't have that monitoring that we have, so they put them all on aspirin. That's a bit different to us. And then perform a C-section for well-indicated GI reasons. And then when you look at the fetal outcomes, you would say here again, body needs to focus on baby, not on the bowels, and disease control results in healthy weight, avoidance of neonatal ICU, and a healthy neurological and immune system. And that's why when you look at the vaccines, we have demonstrated that all inactive vaccines can be given, and even live vaccines, including the rotavirus vaccine, can be given to these biologic exposed infants. And just one more slide here on vaccines. We do recommend DTaP, RSV, influenza, and COVID. the women have to avoid the live vaccines. But as I've said, we are now recommending the live oral rotavirus vaccine for all anti-TNF exposed babies, in addition to the non-live vaccines, and soon to follow for the other biologic classes. So in summary, before we get to the questions, don't forget, what's the impact of IBD on pregnancy? Active IBD will lead to adverse maternal fetal outcomes. What's the impact of the pregnancy on IBD? It's the UC patients that are more likely to flare. Don't forget that rectal 5-ASA. Safety of medications in pregnancy and breastfeeding. The concerns are only with methotrexate and with the JAK inhibitors. We're continuing to collect data and have used it in select cases, and so far have not seen a signal for human teratogenicity, even though it was seen in animal models at very high doses, but still we are investigating that. Obstetric care, we've talked about mode of delivery, aspirin, and doing that 12-week ultrasound that can help prognosticate, DVD prophylaxis if a woman has active disease, and preventive care, happy, healthy mum. Make sure that you consider nutrition. Mental health is so important. We've already demonstrated in our studies that there's an increased risk of mental health abnormalities in women with IBD. It's a stressful time. Cancer surveillance, don't forget this. This is a separate topic, but pap smears, colonoscopies, MRCPs for those with primary sclerosing cholangitis. Remember, your IBD women are often frequent flyers. They'll have one baby, then have another one, then have another one. And then if you don't jump in and do this preventive care in between, it gets forgotten. Then 5 years or 10 years has gone by and they are not up to date. And we've talked about vaccines. So in summary, check out the website. It's pianostudy.org, or you can just Google piano IBD. And remember, be more concerned about active disease than active medications. And with that, I'll be happy to answer any questions, because I know that I missed a few up the top, but I will let Marie-Louise come in and moderate. Thanks, Emil.
Thank you, Dr. Seow. That was an excellent presentation. We have a question from Usha. What about male IBD patients who are on methotrexate? Should this be stopped or held prior to conception?
Okay, hi Usha, nice to hear from you. So for methotrexate in males, actually the GI as well as the rheumatology guidelines do not recommend stopping the methotrexate. And you might wonder why, but in terms of teratogenesis, it doesn't actually confer an increased risk for congenital anomalies. What methotrexate may do, however, is it may impact on sperm motility to a small extent. So if a male is on methotrexate and the woman is not conceiving, then they actually should be looking at the male fertility in general. So doing sperm motility studies, seeing if methotrexate is the appropriate drug for the male, because obviously it requires both the male and the female for the female to get pregnant. So again, it's that male as well as female health that needs to be considered, because clearly the male is on the methotrexate for a reason and for a chronic immune disorder. But at this time, we do not recommend that men have to stop methotrexate if they're embarking on a pregnancy for the partner.
Thank you. Denise has a question. What can women in their 40s with IBD, Crohn's colitis specifically, do to ensure or try to ensure a smooth pregnancy given the increased risk factor with age?
Yeah, I think it's the same things that modify what you can. And the most important thing from an disease standpoint is just making sure that the disease is as best controlled as it possibly can be, making sure that the mum is linked up with family medicine and then linked up with obstetric care as early as possible, so that all the gestation appropriate investigations are done, because the bigger concerns are firstly whether the woman can get pregnant in the first place, so making sure that nutrition and all of that is up to date. And once they're pregnant, we know that, of course, the older a woman is, the increased risk of chromosomal anomalies and all of that. So it has to be just discussed. It's actually very similar to any other sort of advanced maternal age pregnancy.
Thank Thank you, Dr. Seow. I'll combine Jen's question. Have you seen any maternal or fetal complications with being on a JAK? And she has a patient coming in on Thursday who is on Rinvo for 3 months and now has an unexpected pregnancy. Can you briefly highlight the discussion you may have with her?
So I would so firstly there's only been animal data that has suggested an increased risk of congenital anomalies with JAK inhibition. The data for humans, so the first published study is of 128 pregnancies. I think 84 of them were in clinical trials, and the other 44 were, sort of accidental for lack of a better word, unexpected exposure during a pregnancy. For that particular registry of those 128 pregnancies, they only saw one congenital anomaly. It was a congenital heart defect. It wasn't incompatible with life. In fact, it was minor, but still get it. It's still a concern. So when you say 1 out of 128 pregnancies, is that an increased risk? That's not actually more than the baseline risk. In general, you would say that about 5% of pregnancies may be affected by a congenital malformation of some sort, ranging from minor to major. So that if you look at the WHO guidelines, it's about 5%. So it didn't appear that JAK inhibition significantly increased the risk of congenital anomalies. Having said that, for all of those women, the median time for cessation of the drug was 5.5 weeks, so they didn't continue throughout the pregnancy. We're now part of a global registry for JAK inhibition in pregnancy, where we've had no choice but to either, they were on the drug, they got pregnant, and it was needed for maternal health. What was published at UEGW in October and will be updated for ECHO, which is coming up in 2 weeks, is 55 pregnancies that were exposed. Those patients, that almost all of them went through the majority of the pregnancy on the JAK inhibitor. We have not seen congenital anomalies with that. However, we did note that at one stage, 1/3 of the women stopped the JAK inhibitor early in the pregnancy because they were worried about it. And of those, more than half of them flared. So my messaging, trying to make it simple, is, if this woman is already on a JAK inhibitor and that is holding her pregnancy at this point in time, if it's holding her disease at bay, and if she's already past the first trimester, I would have no concerns. I would continue it for the remainder of the pregnancy. There will have to be a discussion about about the JAK inhibitor during breastfeeding. At this time, we're still studying it. I think we always tell women, that is your choice whether you want to breastfeed. We don't want to take that either that pleasure or the bonding away from the mother. So it's a detailed discussion. But we also know on the flip side, not every woman can breastfeed. So at this point in time, we know that small amounts are transferred into the breast milk because it is an oral small molecule. We have an N of 2 for what it's worth, but that's 2 more than anywhere else in the world, who have gone for immunophenotyping of these babies whilst they've been breastfed on a JAK inhibitor at full dose JAK inhibition, like 30 milligrams a day, not on dermatology doses. And we did not see any impact on the baby's immune system. So one, again, if you have time to transition before pregnancy, not in this case, you can have that discussion, but you do have to give them that time. People say 3 months. I think you need 6 months to stabilize them, because we all know that, people don't necessarily flare in a short period of time. 2, if you have no other choice, continue it with this, counseling, that we want to keep the disease under control, because that is the most important thing. 3, if they're going to breastfeed on it, if you are at a site where you can access pediatric infectious disease, and if they want reassurance, they can be sent for immunophenotyping. But having said that, we haven't seen a signal for abnormalities at this time. So it is a very vexed discussion and everybody's asking about it. But hopefully I've put it in context. Just let me know if you need any other help or if you want it more clear.
Thank you. One more question from Karen regarding the fetal heart rate monitoring. If the monitoring was abnormal before the sigmoidoscopy, would you cancel it?
It's so the fetal heart rate monitoring for us is just actually a Doppler. So it's just to really assess whether there is presence or absence of heart rate. So it's really only assessing for fetal viability. It's not the same as one of those fancy, CTG tracings and things like that. We're just trying to see this woman is sick. Her baby may or may not be viable anyway because the active disease may have impacted on that viability. That's all we're checking for. And we're saying we need to check this so that we can do the SIG, then find out what we need to do going forward. And I wouldn't try and minimize doing SIGs in patients. If you don't know what to do, do it. Because on the flip side, if your patient has a little bit of bleeding, maybe a little bit of urgency, and then you're not sure, is it hemorrhoids or something else? You know what? It's still much safer to do a SIG on that patient than just put them empirically on steroids, right? So for me, I would still do that. And obviously, if there is absence of a fetal heart rate beforehand, these are the labor and delivery or triage nurses that are coming down. They will call for obstetrics help.
Thank you. I have hopefully a quick question.
Yeah.
If you have a bio-naive, advanced therapy naive female who's planning on conceiving in the next couple of years, given you have the most data on anti-TNF therapy, would you prefer anti-TNF or are you comfortable recommending any of our biologics?
Yeah, that's an excellent question. I think we know that as a class effect, they're all large IgG1 monoclonal antibodies, so none of them will cross the placenta in the first trimester. So in terms of congenital anomaly risk, there is no difference. All of them will transfer very rapidly on the second and then into the third trimester. But again, we haven't seen any effects on the baby's immune system from that exposure. I mean, I think you have to judge it on the mum if they want the totality of evidence. Of course, there's more information about the anti-TNFs than there are for the other newer therapies, but it wouldn't necessarily dissuade me. So, to use a newer or different non-anti-TNF monoclonal antibody. And, again, we have some that are 17, 18, 19 who start coming obviously to our clinics, the ped adult clinic. That's why you need to start that sex, drugs, rock and roll discussion, because we do know that there are many unexpected pregnancies. In fact, that global registry of the 55 women, I think there was something like a quarter of them were unplanned pregnancies. And then you got into this dilemma. So I don't think you should avoid necessarily using any small molecule, but keep that discussion open, which I know that IBD nurses do much better than physicians of discussing sex, drugs, rock and roll and asking for what their future plans are, because it is important.
All right. Thank you. I think that's all we have time for tonight. Thank you very much for your time and expertise, Dr. Seow. Thank you to everyone for joining us. Please, if you have any webinar suggestions coming up, please let us know through the CanIBD website. But we hope you have a fantastic night.
Thank you. And I really appreciate the invite. And if you want to go onto the gutsy talks and things like that, you'll see a similar slide deck. And as Marie-Louise knows, please, I'm very open to you guys. If you need help, email Marie-Louise or myself. We're happy to help you out with any questions.
Yes.
Okay.
Thank you, everyone. Have a good night.
Thank you. Good night.